Hi, everyone. So we're going to get started. So I'm going to be introducing Dr. Katie Colborn. She is an assistant professor in the Department of Biostatistics and Informatics at the School of Public Health, and also a senior investigator at the Center for Global Health. And she's done a lot of interesting stuff over her career, but today she'll be focusing a little bit on her research from Mozambique that was NIH-sponsored among other groups, and is currently sponsored by the Bill and Melinda Gates Foundation. And today she'll be talking about spatial-temporal modeling of weekly malaria incidence in children under 5 from her time in Mozambique. Thanks, Katie.
Hey, well, thanks everyone for coming. This is an exciting opportunity because we're just kind of finishing our work that we've done on phase 1 of a Grand Challenges Explorations grant through the Gates Foundation. And today I'm going to present a framework that we've developed for a malaria early warning system. And hopefully in phase 2 we can implement this and sort of refine it. But what we've done so far, I'll go into our system, but a little bit of background on malaria for anyone in the room who's not familiar. And then this is an early warning system, as the title suggested, for Mozambique, which is a country just northeast of South Africa, and has a very long-standing problem with malaria. So I'll talk about the malaria burden in Mozambique. And then our framework or sort of the history of malaria early warning systems. We're not the only one working on this problem. And there have been a number of early warning systems developed over the last 2 decades. And then I'll talk about the role of climate and how these relate to early warning systems, because malaria is a climate-sensitive disease. And then I'll talk about our technique for developing a malaria early warning system, which includes the use of exceedance probabilities, which inherently model the uncertainty in our early warning system, and then show you how we're beginning to implement this for our partners. Okay, so malaria, you get malaria from an infective bite by an Anopheles, female Anopheles mosquito. You're infected by one of 4 parasites that are most common. They're Plasmodium parasites. The most common species in Africa is Plasmodium falciparum, and it's also the most virulent. People end up the sickest, and it causes the most mortality. And what happens is you're bitten by a mosquito, the parasites enter the bloodstream, they go into the liver, hang out for a little while, mature, and enter the bloodstream. And it's this gametocyte stage where a mosquito can bite a person and pick up the parasite and then pass it on to another person. And this process takes between 7 to 14 days usually before you begin to feel symptoms of malaria. So malaria is the clinical manifestation of the parasitic infection. So the global burden of malaria, just briefly, there's 212 million cases worldwide in 2015, an estimated 429,000 deaths, 92% of which were in Africa. Deaths mostly occur in children under 5 and pregnant women. There are 91 malaria endemic countries in the world. There's been some recent progress, so 21% decrease in malaria incidence between 2010 to 2015, and 29% decrease in mortality. And the U.S. contributes a lot of money annually to the global malaria burden, 32% of the total across the world. So these are some maps produced by the Malaria Atlas Project. The Malaria Atlas Project is a group at Oxford University who receives funding to do a number of things, but what they're really good at is mapping the global risk of malaria. And they do this by resourcing different data sources from research projects or routinely collected data from health centers. And you can see that there has been improvement. So 2000 to 2015, the red and yellow areas being higher malaria incidence. But you can see over there on the bottom right corner above South Africa, almost the exact shape of Mozambique you can still see on this smooth map. So Mozambique is a real problem. Here's the shape of Mozambique, if you recognize it from the last slide. It's a fairly large country. It spans a large geographic region and has a population of around 28 million. And in 2015, there were an estimated 8.3 million cases and 15,000 deaths. And this is estimated, right? So we rely on reported data from the country, which has improved over the last couple of decades, but this certainly could be an underestimate of the burden. So why does Mozambique have such a problem in malaria? Well, it's in sub-Saharan Africa, but it has some unique features that make it especially vulnerable, one being that it has very low GDP, very rural and low income population. People sometimes use bed nets for other reasons, like to protect water sources. It has a distinct rainy season, which coincides with the higher incidence season. And it's a tropical climate, so ideal setting for Anopheles mosquitoes. So malaria in Mozambique is highly geographically correlated. There tends to be more in the north than in the south. Those maps I showed earlier kind of showed that, and also showed that there's been a recent increase over the last few years after several years of improvement in terms of reducing the burden. There is a system right now called the Canal Endemico, and it's designed to detect weekly case counts that are significantly higher than historical averages. So it's sort of, today we got a report from a health center, it's higher incidence than we would expect. Now that's useful to detect a current outbreak, but it's not so useful if you want to perhaps prevent an outbreak from happening in the future. And so that's really the idea of a malaria early warning system, is to say, we have the Malaria Atlas Project. They can tell us where malaria tends to happen and when. But is there a way we could determine when and where there might be incidents exceeding what we would expect given historical averages? Okay, so every year malaria programs will put together their operational plan, and they can look at a map and say, here's the higher risk region, we can send X amount of resources there. But what if throughout that same season things go differently than what you've seen in the past? Is there a way we can develop a system for predicting when that might happen? So that's what early warning systems are, and it was inspired, a lot of these were inspired by a WHO rollback malaria report published in 2001 detailing the need for these systems. And there have been a number of papers published where people have developed these. They often use climatic data, and I'll talk a little bit more about why. And the best MUs, the ones that are the most successful, require longitudinal data sets of routinely monitored populations, right? So the reason for this is if you want to predict something happening, you need to understand how the transmission tends to behave, okay, in the past. So you need some retrospective data set of routinely collected information on cases, and then given the fact that malaria is associated with climate, you can utilize free resources for climate data. So these are key features of building a malaria early warning system. And the reason is, so temperature and rainfall are important to consider because they tend to affect mosquito breeding development of the parasite and survival of the parasite. And in Africa, in these tropical climates, tends to be a very ideal setting for both the parasite to thrive and for mosquitoes to survive and reproduce. So there's a number of sources for obtaining satellite-derived data on climate. We have chosen to use in this project the FLDAS, or the Famine Early Warning System Network. It was a data set created specifically for Africa, and it's available at 1 day lag. So today we could get yesterday's climate data from Mozambique. And it's available at a relatively small spatial resolution, so that's important when you're trying to correlate it with case counts. And of course, it's free. So we set out to develop one of these early warning systems for Mozambique. And the unique thing we had here is a good relationship with the National Malaria Control Program. So we had access to the entire country's data from over 7 years. We chose to use 7 years because we felt like anything before 2010 might not be as reliable. And this includes weekly case reports from every district in the country of Mozambique. There's 142 districts. And the goal was not to just predict incidence. So this is what a lot of early warning systems do, is try to get a point estimate of the incidence at a given time point, but to actually predict the probability that malaria incidence will exceed a policy relevant threshold at least 8 or 26 weeks in advance, the advance warning being limiting to how well we can develop this model. And policy relevant threshold, I'll explain it in a little bit, but we just set it arbitrarily at twice the relative risk of what we would expect given historical trends. And our second objective is to build this up and produce a platform for implementing this so that our partners could actually use it in practice in Mozambique. So again, we have incidence data, actually case reports of clinical malaria, so cases from all the 142 districts, and then we used population data downloaded freely from the World Pop website and used the 2007 census data to get an approximate estimate of the proportion of the population under 5. So we're using cases under 5 because the data are reported in under 5 cases, over 5 cases, or total. Now, with malaria, people will develop immunity to, they can get infected with Plasmodium parasites, but they might not develop symptoms. So they're not going to report to the health center. So there are actually a number of people, in fact, a very large proportion of the population walking around infected with Plasmodium that actually aren't sick with malaria. And these are the adults who have lived in the country and have developed immunity. So we decided to really look at trends in the transmission patterns. The under 5 population would be more indicative of outbreaks and current transmission intensity. So just a snapshot from our data, under 5 malaria incidents per 1,000 population in week 8 of 2016. You can see the spatial variation in the transmission, and also that it tends to be the burden tends to be a lot stronger in the north, near the border of Tanzania and Malawi. And this little bit that comes down in here is actually Lake Malawi. And looking at our data, so if we just look at all 142 districts reporting weekly case counts across the 7 years, you can see there's a lot of variability. But if we smooth through that first plot and we zoom in, you can see there's a real seasonal trend, a peak and a trough. And down here you can see over time, over the years, 2010 to 2017, we are seeing an average increase in transmission across the country. And this is just a smooth version of a sort of seasonal pattern, and we just see that sort of going up. So it's not good news for Mozambique. And here are just some simple plots of some of the climatic data that we are looking at in relation to the incidence. So the top left is incidence. 2017, we only have a few weeks of data, so really total temperature or total rainfall in 2017. That's why it looks a bit odd there. But you can see sort of a general trend in some of these other factors going up in the same years that incidence has gone up for malaria. Furthermore, if we standardize the values, so the red line is standardized temperature, blue line is standardized rainfall, and the black line is standardized incidence. You can see how there's a lagged influence of temperature and rainfall on malaria cases. So if you look over here between 0 and 10 weeks, rainfall goes up, temperature goes up, and then a few weeks later, maybe 4 to 6 weeks later, incidence goes up. You can see it happen again at the end of the year. And this is averaged over all the years. But there does appear to be a pattern in terms of a lag in rainfall and temperature and cases. Now this should be obvious because if somebody shows up in the health center today, they likely were bitten 7 to 14 days ago. So their exposure was at a minimum 7 to 14 days ago. Now, we hypothesize that actually weather variables such as temperature and rainfall affect mosquitoes at an even bigger lag than that. So we looked at, in our model, which I'll describe here in a second, lags in terms of the correlations between temperature and incidence, and we sort of arbitrarily set these at 2, 4, and 8 weeks, and just tried several lags in our model. But these are fixed factors, measured variables. We know malaria malaria is associated with many different factors that we couldn't possibly measure all of them, right? It'd be great to have information on mosquito populations, proximity to water sources, but these are district level counts. So there's a lot of variation in exposure within these districts for the individuals that are at risk of malaria. But weather data can be used to help us predict that, and they're easy to acquire. They're free. However, if we stopped there, we'd have a pretty bad model, and I'll show you what I mean by that. But in a statistical model, we have uncertainty. We always have uncertainty. And we can characterize this uncertainty in various different ways. We've chosen to characterize it using a spatio-temporal model, okay, which means we're going to have random effects, and they're going to take on characteristics that are associated with time series data, so autoregressive characteristics, and also they're going to take into account the spatial variation that we see in malaria, which involves estimating distance or including distance into your correlation structure. Okay? So this is basically referred to when we fit it in a model as model-based geostatistics. And one of the innovators in this area is Peter Diggle at Lancaster University. And actually one of our colleagues on this project works with Peter Diggle. His name's Emanuele Giorgi. And they've really advanced the field in terms of statistical methodology for spatio-temporal models. One of the things that they've really, I think one of the most innovative parts of their modeling is not to explicitly just model the point estimates, as I mentioned before, but also to model the uncertainty. And they do this through exceedance probabilities, and we do this in our project as well. So the exceedance probability is defined as the predicted probability that the relative risk exceeds a predefined threshold, or the multiplicative deviation from the expected level of incidence. And again, we set this at twice the relative risk, which basically means in your statistical model, well, let me not get too far. Yeah, I'll break this down. So I don't think everyone in here is a statistician, so I won't get too into the details here. But if you think of a linear model, or a generalized linear model, and even a mixed effects model, we usually have some sigma squared on the end of our linear predictor that represents a mean zero variance to be estimated from the data. Here, we're doing a very similar framework, except now SIT is actually our spatio-temporal random effect, and it's described differently, where we take into account the distance between two districts and also the size of each district. And this is an innovation over traditional conditional autoregressive models, or CAR models, because in this framework we can actually account for districts that change their shape over time. So in Mozambique we had some interesting issues across the 7 years where some districts actually split off into two. And so their shape now is split into two separate districts. And if your model can't handle that, if you will, you're just sort of glossing over that, or you're having to lump that back together and pretend like it's the same district. So it's a flexible framework, and it allows us to, again, let me go back here and real quick. So the point with the spatial or the climatic data is the D sub IT is your typical beta coefficients from a linear predictor. Now in this, we put weather, surface barometric pressure, temperature, rainfall, things like that. And then we also included 2, 4, 8-week lags. We used a lasso penalty, which is just a shrinkage method to select which of those variables is most important. And this was actually an adaptive procedure. So for 1 week, maybe 10 variables were important. For another week, none of them were. But the nice flexible framework that we've built allows us to just choose adaptively over time what's most important for predicting malaria. Because if you think about it, you might really need rainfall and temperature in the high season, but you wouldn't need much in the low season because there's not much malaria. Okay. And then the exceedance probability again here is just the probability that it's going to exceed this predefined threshold that we set at 2. We could set it at something else, and this is part of the idea for phase 2, is to work with the country team to figure out what should these thresholds be in terms of your programmatic response. Because if you make the threshold small, then you have a lot of potential flags for outbreaks, and nobody can respond to all those. If you make it too big, you're defining a very small set of outbreaks, and maybe people will lose trust in your system if you're not really detecting any outbreaks, but they might actually occur. So it's not an easy decision, but we hope to work on that in the future. So what we wanted to do is just test 3 separate models to see if our framework was working well. So the first model, we just used climatic data, no spatio-temporal random effects. In the second model, we used just the spatio-temporal random effects and no climatic data. And the third is the comprehensive model, where we include both. For each of these, we tested on the last 8 weeks of data is the holdout test set, and also 26 weeks to see how well we do predicting further out in time. And we compare these with respect to RMSE and coverage probability. So the coverage probability is just, in my holdout set, what proportion of the observed values actually fall into my estimated confidence interval from my model. Okay? And as we know, if it's a 95% confidence interval, we should get 95% falling in that. Okay? So here, I'm sorry this is a little bit hard to see, but the green and red lines are models 2 and 3. So the spatio-temporal random effects model and then the comprehensive model is the green. And you can see between 0 and 4 weeks, those are the best performing models. They have the lowest root mean square error. And the black line, though, tends to catch up a little bit over time, which makes sense, right? So if I'm trying to predict a trend that includes some sort of maybe sinusoidal pattern, like rainfall and incidence in our data, I'm not really going to pick up that true sinusoidal pattern until I look out a little bit further in time. And if I'm trying to predict some time when rainfall isn't moving around a lot, it's not going to be as useful to my model. Okay, so predicting further out, it's good to have climatic data, but as you, if you're just looking in the first 4 or 5 weeks, you can do pretty dang well with a model that only has spatio-temporal random effects. And that's the autoregressive part of the model. So a model where you have AR1 or autoregressive 1 means 1 week ahead in time and 1 week previously are going to be most correlated with today than 4 or 5 weeks down the road, right? So that's the assumption we make in our model. And you can see the coverage probability. What's really bad about the climatic model only is it's very poor at estimating the confidence intervals. And there have been a number of statistical papers showing that when you exclude random effects in a model where they should be included, you're going to underestimate the variance pretty often. So what we're seeing here is about 1% of the holdout set fall in our confidence interval if we're not including any spatio-temporal random effects. That's quite bad, and we're right around 95 for the other 2 models. So that's good. So how does this look at the district level? So here's the district shapes for Mozambique, and we just picked 4, mostly because these 4 in 2017 showed outbreaks, if you will, at least according to routine surveillance and no real current model that's being implemented, but there were higher than usual incidents in those areas. Sorry how tiny this is. But basically what we have, the x-axis is week, so the red line is splitting the last 8 weeks or 8 weeks, it's splitting the year, so 2016 and then 2017. This is the last 26 weeks holdout set we tried to fit our model to. And the exceedance probability on the right is basically to show us what's our confidence. Okay, so if we think something's going to exceed a certain threshold, but we're only 50% confident, that's like tossing a coin, right? So probably don't want to make a lot of huge programmatic decisions based on a 50% probability. But if your threshold is closer to 80 or 100%, what that says to the end user is, I'm 80% confident you're going to have twice the relative risk of historical average in this district at week 10. So people might be more likely to make a real decision based on your confidence rather than the point estimate. Okay, so that's one of the points we're making here, but you can see we almost never trigger any response because we almost never have any exceedance probability above 0.4 here. So that's just a way of saying not a good fit, or it doesn't work well predicting that far out. And part of that is the autoregressive part. So we know that it should be the most confident within 2 to 3 weeks of today, because that's how our model is sort of built. But if there's true fluctuations, we can pick that up. And you can see this here. So we're getting exceedance probabilities right around 1 or 8, 0.8 in all these districts. And you can see the dots are the observed and our black line is the expected. So for some, it's really obvious that our model is really detecting this sort of variation, which means the random effect is much larger than it would have been otherwise. But then there's some where the dot, the third one down, the dot is sort of right on the line. That might not be the best. We didn't do the best job there. But again, this is 4 districts, and there's 142. So what we want is the model that does the best on average. And so the root mean square and the coverage probability tell us more about our model performance. But this is just to show you we have some real outbreaks that can be detected using this system. Another way of looking at this, and this is probably the way that you would look at it in practice, on the left is incidence. So this is predicted incidence for the first week of January 2017. And then the exceedance probability is the probability that that incidence is actually going to be twice what we would have expected given a typical year. Okay? So the nice thing about the difference between the two is the one on the right has much fewer flags, if you will. You're not going to need to respond to so many. And we're not trying to just create another risk map, right? We want to know, given the resources we've already allocated in our operational plan, which districts are going to have more malaria than we expected, and therefore probably need more resources, right? More RDTs, more anti-malarials, spraying, nets, any sort of prevention methods that you could implement. So let me show you what this looks like quickly. Our colleagues at Lancaster University have developed this prototype website for us to map both the incidence, we're getting predicted incidence, and also predicted exceedance probabilities. So if we look at, we know that the malaria season tends to be a little higher here, week 8. So it looks like up here, this is incidence, okay? So that was 240 cases per 1,000 here in Mavago. But the exceedance map for Mavago in week 8, gives us an exceedance probability of 0.4. So that red district looked kind of alarming on an incidence map, but on an exceedance map, somebody could say, well, we already knew that was going to be high incidence probably at the start of the season. And there's a very low probability that it's going to exceed what we expected. So you might actually not want to respond to the first map of incidence, but perhaps follow this exceedance map that says this isn't beyond what we expected. So, prototype, haven't started implementing it yet, but that's the platform we're hoping to get feedback from our colleagues in Mozambique and have them start using in the future. This was just screenshot back up in case the internet wasn't behaving properly. So there's some practical considerations with our Muse and any Muse. It looks like our model fit better when we're trying to only predict about 8 weeks in advance. And we're probably only going to pick up real outbreaks 4 or 5 weeks in advance if we continue with the AR1 framework. And so the question is that enough time to put resources together and go prevent this outbreak from happening? We're not sure. The second thing is we're predicting on a holdout set where we have observed satellite data, right? So you can build your model in a supervised learning problem where everything is measured already, and we're retrospectively fitting this. Now, to predict in the future, we need to know 8 weeks ahead what the rainfall and the temperature are going to be if we're going to predict malaria. So we're going to need a team of climate forecasters for phase 2, which right now we're just using satellite data, and that doesn't really help for an early warning system, although it's perfect for building your framework. And then we need to connect with the source data, the case data, in a more sort of automatic way. Right now we get data sent to us by our colleagues at the NMCP, but in order for this to be automated, we really need to link with other systems, and so that's one of the goals of phase 2. And then these are my colleagues. I just wanted to thank them for all the work they've done. This is the phase 1 grants are not big. It's $100,000 for 18 months, but we've been fortunate enough to find lots of people who wanted to work on this for free and have really been an integral part of the project. My husband, James Colborn, is a malaria epidemiologist and works for the Clinton Health Access Initiative and works in Mozambique. And Emanuele Giorgi, again, is a statistician at Lancaster. Our other 2 colleagues at the National Malaria Control Program and Institute of Health in Mozambique, and Andy Moynihan, no longer at NCAR, but was at NCAR and is at CU Boulder now, I think so. And of course, the Bill and Melinda Gates Foundation. So, thanks. Any questions? Yeah.
So, how would this really play out in the field? So let's say phase 2 looks good, you got a pretty good model. You go to the district medical officer and say, look, I think in 8 to 12 weeks, we're going to have a problem. And I checked with Yogi Berra, and he said that's correct. So predictions are difficult, especially when they know the future. So you go to the district medical officer and say, we think you're going to have a big problem. What would they do? Would they really go out and distribute more bed nets? Would they really hire 2 more nurses? In essence, because it's most of this is passive case finding. The kids are going to show up. They're going to be sick. They're going to be taken care of them. You might even go back to and say, look, we know this. The rainy season's coming up. We'll see more cases. What would they do with your data?
Well, it requires having some resources set aside, which some countries do. I believe Mozambique is a country that actually either does or will.
They're hoping to, at least in the lower transmission areas.
Yeah. Logistical issues are a problem always in Africa. But the idea would be to have resources that are for outbreak response, emergency response. They have to believe. I think one of the biggest challenges is people believing that your model is correct. And that's why we focused on uncertainty, so that we're not misleading people, hopefully. And then it's really, where are your resources going to be? You'd have to keep them in the north and the south, and we know that there's going to be malaria in the north. If there was a big outbreak in the south, I believe strongly that people would do something, because it's bad for your international reputation when your capital city has an outbreak. People don't want to travel there. So I think, and there's some kind of, in Inyamban, this area around here, very tropical, beautiful sandy beaches, a lot of tourism from South Africans there. So if there's an outbreak, chances are they might want to respond so that it doesn't affect tourism, things like that. It might not really be those in highest need get the resources. It might be, we're going to send the resources where it's going to prevent our economic growth from stopping for a while. So I don't know.
It's a very good point, though, because in much of sub-Saharan Africa, we're already doing everything we can. I mean, it's basically one big outbreak, right? And it's not like you're thinking, well, it's not going to be this bad this year, so we're not going to throw everything we can at it to get rid of the problem. You are already doing all the IRS you can, distributing all the bed nets you can. It's rarely a lack of desire or resources that it's lack of resources, it's not lack of desire to implement this. I think that the key things that would happen in the higher burden areas where you have
I would think moving meds around would be important to do and might be necessary.
Yeah. Of course, it's hard to do anything in the rainy season if it's in a rural area because the roads are bad. So it could just be prohibitive for that reason. So.
I mean, do they have cycles of outreach where about bed nets and folks like that? I mean, is that something they routinely do now?
Yeah. I mean, they're trying to have. I mean, there's a limited geographic range to what happens. It's not like all populations receive these. There are radio spots and other campaigns through religious organizations that let people know to use their net. And then every time there's a mass distribution of nets, there are also the behavioral change campaigns let them know to use it, not use it for fishing, that kind of thing. Whether or not they're effective is another story. People get used to it, you know. I mean, malaria is a way of life in Mozambique and much of sub-Saharan Africa, and it's one of the. I think the potential benefit of this is having some kind of alert that says it's going to be worse than normal, which actually might spur some kind of change in behavior.
Oh, sorry.
This might show my ignorance of machine learning and stuff, but in sort of a minority report question, like if you do start predicting these, then you stop getting data, right? Because
yeah, I mean, to validate in practice is difficult if you immediately start implementing your response.
Right.
So you might need a little burn-in period where you're validating, but the problem is there's only one season of peak transmission in Mozambique.
Mm-hmm.
So do you wait a year? I don't know. I mean, there was a number of malaria early warning systems or dengue early warning system presentations at the American Society of Tropical Medicine Hygiene Conference 2 years ago. And this was one of the things brought up, and people just kind of agree that it's hard to do it, it's hard to validate in practice, because if you actually go and intervene, you shouldn't see the outbreak, right?
Right.
So,
And so if you did validate or if you didn't, you'd just go on this model and hope.
yeah,
And
hope you're doing the right
right.
thing. And you could try it on other countries, but I think the problem is each country would need its own system. Because there's different, like Mozambique is affected by El Nino and La Nina weather patterns and has its own unique little atmosphere that might be different than Zambia or
Right.
nearby countries. So.
How do you enter the spatial data into the model? Are you using like the center point of the districts? Or?
Yeah, so we use like a district centroid, and I think the way, so Andy Moynihan prepared our climatic data, and he uses like a district, basically you end up with these 25 kilometer grid squares that are hovering over the district, and you take 4 nearest the centroid of the district and average those. So there's a lot of sort of uncertainty in our variables on the right-hand side of the equation, for sure, but we're not trying to get unbiased estimates of the influence. We don't actually even care which ones end up in the model and what their coefficient is. We just want to try and adjust, if you will, and get a better prediction. And then the interesting part is we use Bayesian methods to estimate our model parameters, but in doing the lasso, we start with just using a regular Poisson model, estimate the coefficients, and we use that as an offset in the model where we estimate using a Bayesian, the spatio-temporal correlation matrix. So it's not a super easy thing to implement, but it is, once your R code's written, you can just kind of run it doesn't take a long time to run the models, but longer than certainly just a simple longitudinal model. So, yeah.
You mentioned the the threshold is set at 2. Is this one all the same for the whole country or different between like these districts? Or can set this to as maybe a model is floating?
Yeah.
Could it be better?
Yeah, that's a good question. We spent quite a bit of time talking about this because you could set a threshold for incidence to say if incidence is going to exceed a certain threshold. But, as James was pointing out, the North has really high incidence, the South has really low incidence. Maybe it's really concerning to the Ministry of Health when an area of very low incidence increases 1 or 2%, versus in the North, if it's already 50%, do you care if it's going to go up to 56%, the estimate? So we made it relative because then it would be relative to the district itself and its historic trends. But the choice of 2 is quite arbitrary. And so that's something we hope to kind of do in a qualitative study in the next phase, is to work with the ministry to say, how is this working? Like, should we change the threshold? Should we not use relative risk? Should we use something more like stratified risk, south, north, something like that? Yeah, it's a tough call, but.
So how accurate is the actual surveillance data? Is it confirmed malaria? Is it heterogeneous as far as the quality of reporting from different districts? Like high incidence districts do a better job of reporting?
It's a good question. I think it's probably heterogeneous. The malaria expert over here would know more, but.
Yeah, it's heterogeneous for sure, although I don't think that there is a strong correlation between transmission intensity. In general, in terms of reporting completeness, which is somewhat of an arbitrary definition of just the number of health facilities that are actually reporting what they're supposed to be reporting, it's pretty consistent. But in terms of how many when they're reporting a confirmed case, how many times that's an actual confirmed case, it's hard to say using the data that we have. We have new data now where they're required to, each health facility is required to report the number of tests, the number of positive, the number of suspected cases, and all that kind of thing. So we can actually find out how well they're doing. The patterns are, I think, more or less what you'd expect, but there is a lot of heterogeneity throughout the country.
Yeah, and you don't know when they run out of RDTs and just start assuming anybody with a fever has malaria. I think that's happening. That's why we decided nothing before 2010, because we felt like a lot of that might not even be confirmed cases. But then the group from Switzerland who's doing the health facility assessments, paying for the Global Fund to Fight AIDS, Tuberculosis, and Malaria, is paying for a lot of these health facility assessments across Africa. There's one being done in Mozambique, so maybe they'll have data on how good or poor the data really are through those assessments. Yeah.
It'd be interesting to think about, I think there was a big dengue outbreak there in 2012 to see how the model performed that year compared to more routine years, I think, than dengue outbreak, just to see if there was like a new syndromic illness that somewhat looked like malaria, how that affected the model's performance.
Yeah, and I don't know how much dengue is associated with climate either. It seems like it is, because you get these fake breeding sites now and garbage or whatever, but it's different because the mosquitoes breed in different areas, right? Anopheles like clean water, Aedes like dirty water in urban areas. So how that affects what they're doing in the health facility, I don't really know. But I think one thing people are really interested in is how much dengue there is, how much Zika there might have been, and are people just assuming all those are malaria and not really testing?
Yeah, I think at one point there was, during that 2012 outbreak, there was, I think, 20,000, from one area in the country, there were, I think, 20,000 what they called confirmed cases of malaria, and only half of them actually were RDT positive. So I'm sure they were febrile, all those patients, and whether or not all 10,000 of them actually had dengue, who knows? But the other interesting thing is that a lot of these, where the dengue outbreak has happened, where most of the dengue and chikungunya outbreaks have happened, prevalence is, in children from 5 to 15 years of age, for instance, is above 90%. So somebody could get dengue and come in and they get tested with a malaria rapid test, and they're going to get called a malaria case right away. And whether or not that's what's caused it, making them sick or not.
So, could be questionable data at certain times. And that's the thing, we didn't go through the data and say, oh, this looks like an outlier. I mean, some of my students are here from last semester, and there were a lot of questions. I simulated some case data, but I mean, you get some weird observations, and you can't just throw them out because you really don't know. Is that an outbreak, or is that like really bad reporting that week? So that's one of the hard parts about working with these data is there's a lot of variation, and it might be real, and it might also just be bad data collection or reporting practices, and you have to just assume that it's all real. So, okay. Oh.
I know there's a famine early warning system, and they do climatic data. Is there any way to bounce the climatic data off of the malaria early warning system?
Well, we use the famine early warning system's climatic data,
Oh, okay.
and they use that to predict famine, right? But it's the same. It's data created for and produced for that early warning system, and we just use that climatic data because it's easy to acquire and it's collected really frequently. And I forget. Andy Moynihan also gave us some other good bits of information about why it's good, but I mean, I've used various different satellite data from different sources to do other modeling in Mozambique as well. And not being a climate expert, it's really nice to have people who can point you in the right direction, because there is a lot of variability, I think, in some of these satellite data. Some are at larger spatial resolution, some at smaller, and got to know how to work with the raster data. So, yeah.